This is Dr. Caroline Peterson from Natural Women's Health Institute in Sarasota, Florida. Today we're continuing our series on different causes of pelvic pain, and we'll be talking about uterine fibroids. In case you haven't seen some of the other sessions, there are a number of common causes of chronic pelvic pain. We've talked about some of them already, and more are in the works. Fibroids is one of them that many women experience, and so that's our topic for today. Chronic pelvic pain is felt in the pelvis. Pain is felt in the pelvis for more than 6 months, and it affects many women worldwide, although most women do not seek medical care. It accounts for 10 to 20% of all gyne outpatient appointments and 20 to 33% of all diagnostic laparoscopies are actually for chronic pelvic pain, and most of the pain still remains unexplained. Fibroids are benign tumors of the smooth muscle of the uterus. They're called leiomyomas. Leo means smooth. My means muscle, oma means tumor. They're the most common gynecologic tumor, and up to 80% of women have fibroids, although only 30% of those women are symptomatic. This is the primary reason for hysterectomy, so something important for us to explore and understand. There are three main types of fibroids. The intramural fibroid is actually in the muscle, so you can see it here. The subserosal is in the outer part of the uterus, and it at times can become pedunculated, and that means it's on like a little stem. And then we have the submucosal fibroids, which are in the endometrium and also can become pedunculated or on a little stem. The fibroids are made up of excess smooth muscle, excess extracellular collagenous matrix, so too much collagen, and then the fibroblasts that actually stimulate collagen growth. It's important to talk about rare benign ovarian tumors because sometimes they will be mistaken with initial imaging for a pedunculated fibroid. These are very rare, but can cause the same kinds of symptoms with chronic pelvic pain, constipation, and bloating. They're perhaps in women a little bit older, 45 to 60. Fibroids are usually in premenopausal women, generally in their 40s. These rare benign ovarian tumors can be solid or cystic or a combination. One type is called an ovarian fibroma, which is not or almost never estrogen dependent. And the thecomas can secrete estrogen and androgens. So again, these rare benign ovarian tumors are unrelated to uterine fibroids, but sometimes a pedunculated ovarian fibroid can be mistaken for an ovarian tumor. An ovarian tumor can be mistaken for a pedunculated uterine fibroid. Adenomyosis is endometriosis of the uterus, and like all of these pelvic pain syndromes, there can be some overlap. So 15 to 57%. So when you see a range like that, it's just too big. And so what it's telling us is that the study size is not big enough, and that what we really need is like a meta-analysis or something like that, where we can have a larger study to give us a better number, because that range just doesn't make sense. So we could say, up to 57% of women undergoing hysterectomies for fibroids also have adenomyosis. And then 50% of women with adenomyosis also have fibroids. So I would guess that it's the percentage of women undergoing hysterectomy for fibroids who have adenomyosis is probably about 50%. But again, we would need a larger study to actually know with more certainty. The symptoms that are associated with fibroids are abnormal uterine bleeding. So that's heavier bleeding than what you would expect. That means that you would have to change a tampon or a pad more than once every 2 hours, and that the bleeding lasts longer than the 5 days, perhaps 8 days or more. Women who have fibroids also experience pelvic pressure and pain that is generally worse with menses. There's bowel dysfunction, can be bloating. A lot of times the bladder will be affected too. The bladder may not be able to expand well because of a fibroid, and so women will experience frequency and urgency. Sometimes also because of the fibroid pressing on the uterus. In certain ways, there can be urinary retention and incontinence. Depending on where the fibroid is, if it's in the back, it can also cause low back pain. It can cause constipation and pain with sex. African American women are at greatest risk for fibroids. And these women are a little older than what you would generally expect. Perimenopause is the time when most fibroids are identified. Risk factors for fibroids also include obesity, aromatization, SNPs or issues, inflammation and insulin. Basically, all of these things can be called inflammation. These are different sources of inflammation. If you've never had a baby, that's also a risk factor for fibroids. If you have a mother or a sister with fibroids, that's a risk factor for you. If you have hypertension, you have 5 times increased risk of getting fibroids. Vitamin D deficiency and excess vitamin E are also risk factors for fibroids. If you have a diet that's low in fish, fruit, and green vegetables, you are at risk for fibroids. Alcohol use and air pollution are risk factors for fibroids. The data on tobacco is a little less consistent. And then endocrine disruptors are a big risk factor for fibroids, as are heavy metals. So vitamin E can act kind of like a weak estrogen in the receptor, and so it can promote fibroids because of that. Interestingly enough, one of the protective factors against fibroids is hormonal contraception. And this is mostly because it seems to be a consistent low dose that does not allow for proliferation. If we think about fibroids, we want to know if they're increasing in frequency or incidence. So this Global Health Data Exchange database studied 29 years of fibroid incident and found that the incidence year over year has increased globally, and that it is most pronounced in India, Brazil, and tropical Latin America. So of course, we're wondering, like, is it really more Or is it just that more women are getting tested? Because we know most fibroids are silent. And so are women getting tested just because more offices have ultrasounds now, so it's easier to test? Or perhaps in some places there is more healthcare available. So one way to kind of try to help understand that possibility of surveillance bias is to think about the dailies, which means premature death or loss of quality of life due to the disease. And so that was something that was also measured in this database. And so what we see is that there was also an increase in the loss of quality of life or premature death because of the disease. And this occurred more in tropical Latin America and high income North America and Oceania. And so so what this suggests is that there are also more symptomatic fibroids. So to me, this suggests that possibility that not only is there probably more surveillance, and so you're finding more of the asymptomatic fibroids incidentally, but also that there are more symptomatic um, fibroids, which would say that it's not just a matter of surveillance, it also is that there's actually a higher incidence of the fibroids. So when we think about the developmental phases of fibroids, the first phase is in the muscle cells themselves, the myocytes. In the beginning, we just have proliferation of the myocytes. We don't have extra collagen matrix laid down. However, at this time, we are getting more vascularization. So you need the vascularization in order for the monocytes to grow. That makes sense. In the second phase, the monocytes continue to grow, and we're beginning to have some collagen laid down, but it's less than 10%. In the third phase, the monocytes in the beginning continue to grow, and we're getting 10 to 50% collagen in the matrix. Toward the end of this phase, the third phase, then we're starting to see a pulling back of the vascularization, and we're starting to see a little bit of monocyte death because it doesn't have the vascularization to feed the muscle. And so that means poor nutrition, poor oxygenation, and death. In the fourth phase, we're seeing that death of the monocytes because of the poor vascularization, that the tumor, the fibroid, is at least 50% collagen. And usually this is concurrent with like menopause or early postmenopause, when you're starting to see a shift in the hormones also. And so the fibroid may start to shrink at this point, and become smaller, so it may become less symptomatic, although this doesn't always happen. So this is the series. So we have in phase 1, you have a normal muscle cell, and you have the capillaries where the blood is exchanged, and you have perfusion into the end organ or the muscle cell. Next, what happens is that you start to have collagen laid down and increased vascularization. In the third phase, we're starting to get less blood flow, smaller muscles, the muscle cells are dying, and increased collagen. In the fourth phase, we're seeing cell death, and that's muscle cell death. And then that cell can be reabsorbed, and there's devascularization also. And so then what you're left with is a bunch of collagen with holes in it, like a sponge. So again, if we think about risk factors for fibroids, we can think about it um, along other lines. We can think about steroidal hormones as being a risk factor. Now, the steroidal hormones are the hormones that are built out of cholesterol. And so the main ones that people think about are progesterone, testosterone, and estrogen. There are others. Those are the main ones that we'll talk about today. Other risks are the growth factors that the body produces, inflammatory cytokines, chromosomes, and epigenetics and genetics. So now we'll talk about hormones and fibroids. So fibroids are estrogen dependent. And the main reason people talk about it this way is because no fibroids are found in prepubescent girls, and there are a few fibroids that are symptomatic in postmenopausal women. Basically, if you can make it to menopause, you're going to be okay. Most people in menopause, after menopause, don't need intervention. The other reason that fibroids are thought of as being estrogen dependent tumors is because these tumors regress with gonadotrophin releasing hormone agonists. And so that means that it's working on the endocrine system in the brain. And the last reason why they're thought of as being related to estrogen is because the low dose oral birth control is protective against fibroids. It's interesting to note that plasma estrogen, the estrogen in your blood, is actually not increased if you have fibroids. The ovarian production of estrogen is not elevated in women with fibroids when compared to women without fibroids. What's happening is that the fibroids themselves become these little manufacturing units of estrogen that promotes the proliferation. Progesterone is also related to fibroids. So in general, when we think of estrogen, we think estrogen proliferates, it causes growth, and progesterone maintains that growth, it holds it. And so we need both of those things to work together, progesterone and estrogen, in order to have a baby, for instance, in order for the endometrium to be thick, so you can have a baby. Progesterone has two receptors, A and B, that are more highly expressed in the fibroid than in the myometrium. So that means that the receptors for progesterone there are more of them in fibroids than in the muscle of the uterus. So what's happening is that estrogen promotes or induces the estrogen receptor expression. And that in turn is what induces fibroid growth. Interestingly enough, fibroids can grow in postmenopausal women who are on an estrogen and progestin hormone replacement therapy. Progestin is the artificial progesterone. And of course, in a hormone replacement therapy, you're going to have an artificial estrogen. However, these postmenopausal women are not at risk of fibroids if they are only on estrogen postmenopausally. Also of interest about progesterone and fibroids is that if a progesterone receptor antagonist is introduced, fibroid proliferation will be prevented. That means the progesterone receptor is blocked. And so progesterone can't be active to hold that growth. So what we have, this is that factory inside of the fibroids. So we have to start with an overexpression of aromatase and an overexpression of type 1 17 beta HSD. These are the enzymes that promote estradiol, which is the strong estrogen. And so that causes an increased local estrogen level. And that can cause an increase in the estrogen receptor G and the progesterone receptor, and a decrease in the P53, which is a tumor suppressor gene. So you have a decrease in that, and so that will lead to more proliferation. When you have that higher increase of estrogen in the fibroid, it will also promote overexpression of the estrogen receptor alpha. So remember that anything, in order to do its job, has to be in a receptor. If it's just floating around, it can't do its job. So the more receptors you have that are open and available, the more possibility it is for that thing to do its job. So a higher local estrogen level in the fibroid activates overexpression of estrogen receptor alpha, and also overexpression of estrogen receptor alpha is caused by hypomethylation of the estrogen receptor promoter. And so what that means, hypomethylation, is that we're not getting enough methylation, and that will cause overexpression of estrogen receptor alpha. So let's look here at the metabolic pathway for estrogen. So here, everything starts with cholesterol, and it'll be broken down into DHEA, and then possibly it has to make a choice here. It's going to be broken down into a precursor for testosterone, androstenediol. That will then be broken down into testosterone, which can be broken down into estradiol. DHEA can also be broken down into a different testosterone precursor called androstenedione. It's so hard to say. And that also can be broken down into a weak estrogen called estrone. So remember how we were talking about fibroids are promoted with upregulation of aromatase. So here, testosterone is broken down into estradiol via aromatase, and androstenedione is broken down by aromatase into estrone. So both of these aromatase are upregulated. So we're having faster movement down into the estrogens. The other thing that is sped up is this 17 beta HSD1. And so we're getting increased movement from DHEA to androstenediol down to testosterone, very fast into estradiol, the strong estrogen. And we're also having not only fast conversion from androstenedione to estrone, but then estrone predominantly converts to estradiol when you have that 17 beta HSD1 SNP or speed up. So everything is kind of hammering this strong estrogen, estradiol. So the first thing that we're going to look at is this aromatase again. So what we see is that the aromatase RNA is not found in the myometrium or the muscle of the uterus in women who do not have fibroids. In women with fibroids, they do have the aromatase RNA. aromatase is higher in fibroids than in adjacent myometrium. So again, we're talking about the fibroids themselves being a little factory for creating growth. So here again, we see the aromatase that's pulling down the androstenedione and the testosterone into estradiol and estrone. Another thing we see is that the 17 beta hydroxysteroid dehydrogenase type 1 is higher in fibroids than adjacent myometrium. And so here we see that to convert the estrone into estradiol, so the weak estrogen into the strong estrogen, we're using the pathway of 17 beta HSD1. So this is a faster conversion. So you're pushing towards estradiol, because to convert back from estradiol to estrone, you're using the type 2, which is not upregulated. And so we have upregulation of estrone to estradiol conversion in fibroids. And like I mentioned before, it's not only the 17 beta HSD1 is not only active in converting the estrone to estradiol, it's also active in converting the DHEA to androstenediol. And so that's pushing the strong pathway, which ultimately leads to estradiol. And then finally, fibroids have higher estrogen levels than the adjacent myometrium. And we saw before that also fibroids have higher estrogen levels in the plasma. We don't expect to find high estrogen levels in the plasma of women with fibroids. Now we're going to talk about growth factors and fibroids. So the growth factors that promote fibroids, now listen carefully, are the same growth factors that are promoted by GLP-1 and by GLP-1 receptor agonists. GLP-1 receptor agonists are the semaglutides, the Ozempics, the Wegovy, and all of those types of weight loss or diabetes treatment drugs. This is because GLP-1 and GLP-1 receptor agonists promote M2 macrophages. M2 macrophages promote growth factors. And they're the same growth factors that promote fibroid growth. They are the myofibroblasts, the vascular endothelial growth factor, the transforming growth factor beta, the fibroblast growth factor, the platelet-derived growth factor. So on one hand, you may think, oh, well, obesity, insulin, inflammation is a risk factor for fibroids. And so I should be on GLP-1 receptor agonists like semaglutide. But on the other hand, GLP-1 receptor agonists like semaglutide promote the same growth factors as those that promote fibroid growth. And so it may not be the right choice for you, because then you could be getting kind of almost like a double whammy. Chromosomes and fibroids. Up to 50% of fibroids have chromosomal abnormalities. These seem to be primarily related to chromosome 12 and chromosome 7. Genetics and fibroids. The most common genetic mutation related to fibroids is the MED12 mutation that occurs in up to 90%. And so what this tells us, again, 45 to 90% is not a good range. So it's telling us the studies were not big enough, we needed meta-analysis, or that there's too much variance within categories. And so for instance, this genetic mutation is most common in women of African descent. And so they are going to have a higher expression of this than other women. And so if you don't control in your study for ethnicity, then you're going to be having these wide ranges. And so basically, there needs to be a better study done or meta-analysis, because this range is not helpful in understanding what's going on. What happens with the MED12 mutation is that you have increased collagen expression. Now, African Americans are also at greater risk of throwing keloids. However, the MED12 mutation is not related to keloid formation as we understand it now. Another genetic risk factor for fibroid is overexpression of HMGA2 that is found in about 7.2% of fibroids. And this is what causes the myocytes to change and angiogenesis to occur, and throwing more of that extracellular matrix, the collagenous matrix. Also, fumarate hydratase mutations or deficiencies promote growth, but you'll recognize these because you don't expect to see fibroids in younger women. You don't expect to see fibroids in a 20-year-old or a teenager or anything like that. And so if you see fibroids in someone who is young, then you're going to guess that probably they have this mutation. Another gene that can be disrupted is COL4A5 and 4A6. That's in 2% of the fibroids, and it's related to insulin receptors, cell proliferation and angiogenesis, and Alport syndrome. So again, we want to look at the inside of the fibroid and the estrogen receptor A promoter, which is the regulatory region of the DNA that controls expression of the gene that codes for the protein of the estrogen receptor alpha. What we know is that when there is hypomethylation of that promoter, we're going to have overexpression of the receptor, the estrogen receptor estrogen. So by now, most people are most familiar with MTHFR as a reason for hypomethylation. And so many people have already had their gene run for MTHFR. And so the one that is related to methylation is the C677. And so if you have a heterozygous or homozygous SNP or single nucleotide polymorphism of that gene, you are not going to be as good at methylating. So when they looked at increased risk of fibroids for women who had the MTHFR C677 SNP without controlling for anything, they found that these women had a 43% increased risk. That means that for women who either had the homozygous or heterozygous SNP, and all of those were included, women independent of age, height, weight, body mass index, parity, gravity, all of them were included just straight up. There was a 43% increased risk of having hypomethylation related fibroids if you have the MTHFR C677 SNP. When they controlled for confounders, the ones that I mentioned, age, height, weight, BMI, parity, gravity, and also the heterozygous mutant, that went down to 41%. And so what that tells us is that those are almost the same. And so it tells us that this SNP, whether it is heterozygous or homozygous, is pretty strong at promoting fibroids. And what we know is that if you are heterozygous, that means you get one thing from your mom and one thing from your dad, right? And so these genes, if they're both wild type, that's normal. If you have one wild type and one mutation, that's heterozygous. And that's a 40% reduction in methylation. If you get two SNPs, one from your mom, one from your dad, then that's a 70% reduction in methylation. So that's very, very significant. And so, but either way, 40% even is adequate to hypomethylate significantly. So this is the green one is the methylation cycle. The blue one, they're calling it here the DNA cycle, but generally it's called the folate cycle. And then the pink one is the transsulfuration pathway. So this folate cycle, the kind of bluish purple one, is important for DNA synthesis and DNA methylation. And you can see the MTHFR gene is right here at the very bottom. And so what it's supposed to do is come up right here to MTR and contribute a methyl group so that you can get methionine. And so that is methylating, right? And so if you have a genetic SNP in this MTHFR, you have 40 to 70% less swing up here to help to methylate this methylation cycle. And so that's considerable, right? That's then will slow down this methylation cycle because it doesn't have the right building blocks to do its job of DNA repair, gene expression, detox, neurotransmitter synthesis, and hormone regulation. And so MTHFR, SNPs, single nucleotide polymorphisms or mutations, significantly impact methylation, which significantly impacts fibroid. Now we're going to talk about epigenetics and fibroids. What are epigenetics? So by now, many people have an understanding of what epigenetics are. Epigenetics are the things that change the expression of genes, and that can be passed through us for many generations. Epigenetics are the things we do or the things we don't do. What we believe, what we think, what we don't believe, what we don't think, the environment we live in, the relationships and experiences we have. These are all epigenetics. These are all things that can remodel our genes or the expression of our genes and change the way we live in our body. So the epigenetic risk factors for fibroids go way back. They go back even into the intrauterine life of the baby and neonates. And what we know is that if these babies have exposure to endocrine disruptor chemicals, their epigenome will be reprogrammed for life if they don't do anything. And that this programming is is activated because of more epigenetics, like the Western diet, high in processed foods, fat, cholesterol, fructose. And this will then change, kind of activate that altered epigenome in a way that is pro-fibroid. You can also be exposed to the endocrine disruptive chemicals at any point in your life. And this also is pro-fibroid. So let's say here, you're a tiny baby in utero, or you're just a tiny baby been born, and they call it early hit. So you get exposure to those endocrine disruptive chemicals, and you start with a normal uterus, a normal myometrium, the muscles in the uterus. But then what happens is that you're going to start having modifications because of that early genetic hit. And that is going to start changing the coding for gene expression and gene stability and cellular development. And that can lead all the way down here, reprogramming a stem cell, and then in later life, the tumor initiating stem cells. If you have a later hit in your childhood or early adulthood, you can become hyper-responsive to stress hormones because of those endocrine disruptive chemicals. If you overlay that with vitamin D deficiency, inflammation, obesity, hypertension, alcohol, unhealthy diet, dysbiosis, then you're going to have a uterus that's at risk. The muscle cells will be at risk. The cells will be reprogrammed, and then there will differentiate into those fibroid cells and have those tumor initiating stem cells. So the outcome as an adult is fibrosis, DNA damage, too much of that extracellular matrix, that collagen, that fibrous mass being laid down, immune suppression, inhibit the natural death of cells, and have abnormal cell proliferation. That is how we get the fibroids. And that is how epigenetics plays a role, especially those endocrine disrupting chemicals. So what are they? What are the endocrine disrupting chemicals? In general, they're environmental substances that interfere with your body's ability to run its own endocrine system. So it can be in food, it can be in the things you put on your body, the things you wear, what you sit on, the air you breathe. It can be anything that's manufactured. These endocrine disrupting chemicals act as hormone mimics. They block your natural hormones and they act as hormone mimics. And they impact how natural hormones are either made or broken down, and can lead to the production of fibroids. So some of the endocrine disruptor chemicals are organophosphate pesticides. And so those will be found on fruits and vegetables, for instance. 17-alpha ethinyl estradiol is part of the synthetic estrogen in oral birth control. Fire retardants, phthalates for making plastics flexible. BPA to give durability to plastics. Perchlorate found in fertilizers and explosives. Arsenic is in water and rice because it's in the land. Perfluorinated chemicals that are in the non-stick pans, for instance. Mercury is in seafood, light bulbs, and in dental amalgams, for instance. And dioxin is a byproduct of natural industrial processes. These types of endocrine disruptors can cause a lot of problems related to the endocrine system. When we're talking about the endocrine system, we're primarily talking about thyroid and reproductive issues, whether that's infertility, or if it's insulin resistance, that would be related to like PCOS and infertility. And it promotes cancer related to diabetes, cardiovascular disease, and that's basically the overview. Some pretty bad things that are not uncommon right now, that are pretty common. So again, we're talking about examples. The phthalates are in your lotions and things like that, children's products, plastics, polychlorinated biphenyls, PCBs are in industrial solvents, lubricants, electronics, building materials. Dioxins are in industrial solvents. Glyphosate is in pesticides like Roundup, and BPA is in plastics. So awesome, right? I'll just avoid it, right? I'm just going to avoid bisphenols, right? Because I see on my bottle it says BPA free. But if you have a bottle, let's say a baby bottle, that says BPA free, it will still have some bisphenol in it. It may be BPB, BPC, because now those aren't regulated yet. And so, but it does the same thing because they're all bisphenols, right? So there's a whole range of them. And so right now, they're not all regulated. And so you're going to get something if you have a substance that has the qualities of making the plastic durable, like for a bottle or a plate or something like that, a storage vessel. So again, just to recap, conditions that the endocrine disrupting chemicals are associated with are the problems with fertility. That includes endometriosis, adenomyosis, fibroids, early puberty that we're seeing now. Girls are going into puberty a couple years early, boys are going early. Nervous system and immune function, metabolic issues, obesity. Who isn't obese now? Who doesn't have prediabetes now? Cancers, breathing problems, heart health, growth, neurologic and learning disabilities, all are associated with endocrine disrupting chemicals. So the sad part of it is that these endocrine disrupting chemicals are not just in your bottle or your plate or your curtains or your carpet. These endocrine disrupting chemicals will throw that stuff away, and then it gets into the soil, and then it rains, and then it gets into the water source. And so these endocrine disrupting chemicals permeate our contemporary environment. They are xenobiotics, and so they act as our natural hormones. They mimic our hormones. They cannot completely biodegrade, so they are with us forever. They cannot, once they get in the water, they cannot be completely bioremediated by conventional water treatment. And so they're in the water you swim in, they're in the water you bathe in, they are in the water you drink. Even if you buy spring water in a plastic bottle, more than likely you're going to get some EDCs. And also they bioaccumulate. And so that means that they let's say so in natural medicine, we always say eat the sardine instead of the tuna, right? Because that's bioaccumulation. Bioaccumulation is biomagnification. And so the heavy metals that are found in a tuna are much greater than the heavy metals that are found in a sardine. And so that's the same thing with these endocrine disruptors. They biomagnify. The more that they accumulate, they magnify. Air pollution is another risk for fibroids. And in the I'm not sure about now, but before, the EPA used to consider particulate matter to be the pollutant category most damaging for human health. Chronic exposure to particulate matter 2.5 microns large, along with exposure to ozone, increases the risk for symptomatic fibroids. Air pollution increases the risk also for infertility, menstrual irregularity, and endometriosis. So, I mean, some of this is stuff that you'll be doing, right? So if you smoke, let's say, if you cook smoky food, if, you know, fry or something like that. So you can create this particulate matter. But a lot of the particulate matter is actually created by industry and things like that. Things that are outside of your control and that need policy and regulation to make go away. 2 daily alcohol drinks increases the risk for uterine fibroids. And this could be because alcohol promotes steroidal hormones, growth factors, cytokines, and also DNA damage. There are inconsistent findings about cigarette smoking and fibroids. It could be that the studies so far are not universally associating cigarette smoking with fibroids because smokers have lower estrone and estradiol levels. And so in a way that's protective. Biomedical treatments for fibroids, the first choice is contraception and the oral contraception typically. They also will give the gonadotrophin releasing hormone agonists, aromatase inhibitors, selective estrogen receptor modulators, and selective progesterone receptor modulators. If those things don't work, their next step is going to be something more invasive, like an endometrial ablation. That's where they use radial frequency, heat, freezing, electrocautery, microwaves to kill the little fibroids in the submucosa. Also, they can use uterine artery embolization, is when they block the blood vessels that are feeding that particular fibroid. A hysterectomy is also common with fibroids. Myomectomies are less common. That's where they either cut open your tummy or do a laparoscopic surgery or go in through the cervix and remove the fibroid, but they keep the uterus. So this is a picture that's showing right here the uterine artery going up to the uterus. And so what they'll try to do is just embolize the section of the artery that is feeding the uterus. And then they will lead the ovarian artery and the round ligament artery to continue feeding the uterus and hopefully take up the slack. So if you have a myomectomy, there is up to a 33% risk of fibroids reoccurring, and 10 to 21% of women who have had a myomectomy get a hysterectomy within 5 to 10 years. So sometimes the myomectomy is done if women want to still have a chance of having a baby. But I think that nowadays, commonly, it's not a top choice for intervention. Now let's talk about some of the natural treatments for fibroids. So you can start by thinking about what speeds aromatization and promotes fibroids, because we know fibroids have increased aromatization. So obesity, inflammation, high insulin, those things increase aromatization. So if you can become more active, change your diet, you know, things like that, that can decrease obesity, inflammation, high high insulin. Also, some herbs are going to speed aromatization, like forskolin, white peony, licorice, rutin, and quercetin. So those are things you would probably want to avoid. And so remember here, we're talking about the pathway from cholesterol down into estrogen. And here's the aromatase that breaks down the precursor to testosterone and also testosterone into the estrogens. And so we want to slow down those pathways, which are sped up by obesity, insulin, and some herbs. So things that slow it are apigenin. That's going to show up a lot here, a bioflavonoid. Quercetin, another flavonoid. Genistein, an isoflavone. Phytoestrogen. Grapeseed extract, and red wine polysaccharidine dimers. Also, there's an antifungal medication called Azole, which slows aromatization. Metformin, so that would be dealing with the insulin. Glyphosate, interestingly, slows aromatization. And of course, PCOS would, because it backs up into the androgens. And so less estrogen, more androgens. So another thing that's sped up is 17 beta HSD type 1, converting the estrogen to estradiol and promoting fibroids. That again is promoted by abdominal obesity, alcohol, rutin, and the bioflavonoids. So here we have it again, our steroidal metabolic pathway from cholesterol breaking down into the estrogens. And here we have the 17 beta HSD1 that converts estradiol to estradiol. So to slow the 17 beta HSD type 1 conversion from estrone to estradiol, we can use, again, the licorice, the apigenin, and the phytoestrogens. So remember, inside of the fibroids, we have increased progesterone receptor expression right here because we have increased local estrogen levels. So herbs that act as progesterone receptor agonists include bicoline, which is in scutellaria, prunitin, which is in red clover, and apigenin. It actually is kind of interesting because it also can degrade the progesterone receptors. So it has a little bit different function. It's not a receptor antagonist in a strict sense because progesterone outcompetes apigenin, but it does degrade the receptors. So that's a bonus. We also are interested in the herbs that inhibit the estrogen receptor alpha. The camphorol will do that, and in addition, it will inhibit the growth of hormone-dependent tumors. The EGCG, which is found in green tea, also the catechins in the EGCG outcompete the 17 beta estradiol at the receptor level, so it blocks the receptors. Now, if you do have a problem with the folate pathway, the folate carriers, the EGCG can also block the carrier of folate, and so this is something that you would want to avoid. And then we have black cohosh, which downregulates estrogen and progesterone receptors. Another thing to think about is honokyo. It is taken from magnolia, and it is used widely for fibrosis. However, I was not able to find any studies on uterine fibroids. It is anti-inflammatory, anti-angiogenic, and anti-tumor. So those are all things that are good to have if you have a fibroid. It will inhibit fibroblast proliferation and transform, that is induced by transforming growth factor beta 1. And it will inhibit the synthesis of the extracellular matrix components, including fibronectin and type 1 collagen, which is what we see in uterine fibroids. So this could be a good consideration. Another thing that can help for small fibroids and adhesions is castor oil packs. I don't know that they would be super effective on big fibroids. They may increase the inflammation, but in an advanced case, their use could be limited. What you want to make sure of with castor oil packs is that you have enough castor oil on your flannel. You want the flannel to be thick, 4 layers thick, and you want to have about 12 ounces of castor oil on that. And then you want to have that heated up to skin temperature before you put it on your tummy, belly button to pubic bone. So the uterus is just above the pubic bone, and so you want to get it all the way down on top of the pubic bone. And then you want to leave it on for 2 hours with a heating pad on top of it. You want to do it 2 nights in a row, then take a break and come back for another 2 nights. And so this can help with smaller fibroids, perhaps, and perhaps for discomfort with larger ones even. So the problem with these endocrine disruptor chemicals, like we were talking about before, is that, I mean, you can make a personal choice about what cookware you use, what you store your food in, you know, what if you're gonna nail down your hardwood or you're gonna glue it down, you know, you can make all those kinds of choices. But making those choices are not enough to change the environment we live in, because we consume water, we breathe air, we go outside of our houses. And so this is a larger issue. This is a societal issue that needs to be addressed through federal regulation to protect us from these endocrine disruptor chemicals that are not good for us. Pharmaceutical prescription and proscription is outside of my scope of practice, so I'm not saying this as a healthcare provider. I'm just pointing out the research that says that GLP-1 receptor agonists like semaglutide, Ozempic, and Wegovy behave in similar ways to the chemicals that promote fibroids, because GLP-1 receptor agonists stimulate M2 macrophage activation, which then drives myofibroblasts and growth factors that drive fibroids. So one of the ways that we can test for environmental toxins is through Mosaic Lab, the Tox Detect. A lot of labs have these tests now. These are metabolite tests, and so they're looking at the P and seeing if you have more or less metabolites than what they would expect. So this is not necessarily if you have a high, if you have a low report, it doesn't necessarily mean that you're home free, because it could be that you're not excreting, and that can be even more of a problem than somebody who is excreting at a high level, because you're supposed to excrete this stuff. But if you can't excrete and you have a low level, then you have a worse problem, because you're just keeping these toxins in your body. But what I'm saying is that it's probably good to work with a healthcare provider on this instead of trying to figure it out on your own. So the way that these environmental toxins are detoxed primarily through the liver. And so you want to probably perpetually be on supplements that detox the liver for phase 1 and phase 2. If you have a genetics MTHFR SNP, you probably also want to be on a supplement. So what you want to do is come in with the folate right here at the 5-methyl THF, so that you can kind of bypass the slowed MTHFR and get that methylation up into the methylation cycle. Heavy metals are another environmental issue that's associated with fibroids. A lot of labs will test for heavy metal. You can do it through your hair. You can do it for a pee. You can do it with a challenge test, where you try to provoke the body to move out the heavy metals. The main thing to think about is that before you do any work or assessment, I would say, of the heavy metals, you want to check the blood-brain barrier. Because if you have a leaky blood-brain barrier, the metals are all going to like get sucked up into your brain, and that is not good. And so you can test the blood-brain barrier by doing a simple test at home, taking 1 gram of GABA and seeing what your response is. Or you can do an expensive test like Vibrance Neural Zoomer Plus and see if you have a leaky blood-brain barrier. If you do have a leaky blood-brain barrier, you definitely have to seal that first before dealing with any heavy metals. And then you can deal with the heavy metals through a whole range of things, from IV chelation all the way down to homeopathics. So in conclusion, if you want to use a natural method for managing fibroids, you have to start early, because once they're established, a lot of the natural methods are not going to have enough bang for your buck to be able to make a really big change. And so you may need to manage them with biomedicine. Another really important thing is that many of the risk factors for fibroids are actually environmental, and that these are not personal choice issues. These are things that require federal regulation to protect us from the air we breathe, the water we drink, and the environment that we live in. If you do need to get a biomedical procedure to help manage your quality of life with the fibroids, make sure that you seek out manual therapy afterwards for help with the adhesions and recovery. And at that time, it would probably be a good idea to go on a natural medicine protocol to ensure that the fibroids don't come back. Thank you so much. This is Dr. Caroline Peterson at Natural Women's Health Institute in Sarasota, Florida.